The remainder of the forum will be dedicated to questions and answers between the audience and our panelists. So really quickly, I printed off a quick review of some of the bills that have either passed or that have been passed, both good and bad. The major two that I would like to highlight for bills that are not such a good thing for maternal health in the state of Texas are Senate Bill 8, which was passed, Senate Bill 8 by Senator Charles Schutt-Aine, really negatively impacts abortion access or termination of pregnancy access after 14 weeks of pregnancy, when it's still within the what is defined constitutionally as the legal early abortion period. And it includes provisions that copies a federal ban on insecticide adaptation and extraction. It adds prohibitions on donation of embryonic and or fetal tissue. It makes a requirement that the embryonic and fetal tissue from a termination has to either be buried or cremated. It makes it mandatory that physicians providing these kinds of services report electronically monthly. And it also tinkered with the actual legal definitions of abortion and criminalizes the use of surgical instruments in D&E procedures if this procedure is used after 14 weeks. And then another bill I wanted to highlight that did pass and has been very controversial is Senate Bill 4 by Charles Perry. This does not have maternal language necessarily directly in the bill, but as I alluded to in the introduction to the whole forum, maternal health is pervasive in all aspects of healthcare and vice versa. Things that affect healthcare affect moms or moms-to-be, and or dads for trans men. And the Senate Bill 4 essentially it attacks sanctuary cities and tries to go around some constitutional things. It's being debated whether or not it's constitutional. There's multiple things going on still. But it requires compliance with federal immigration authorities to the extent that they'll remove elected officials that refuse to comply. It allows campus, local, and state police officers to question a person's citizenship during routine stops, even traffic stops, including questioning their children. So anytime that mothers or mothers-to-be are worrying about if they go to see the doctor, if they try to get in for the first trimester prenatal care that we talked about, oftentimes with patients whose citizenship status is in question, they might not present for care at all, which can obviously set us back in terms of trying to get people to see us sooner and get on prenatal care earlier or in postpartum care also. So those are some of the bad ones. There were a couple of victories this legislative session, though. There were several. I'm just going to read off the bill numbers and just kind of summarize a group of them. So Senate Bills 1599, 790, 257, as well as House Bills 281 and 1729, in one way or another affect how we collect data and how we report data on various pregnancy, sexual violence, things like that, as well as the last three I mentioned were all relative to rape kits and how we track where they are, whether or not they're being evaluated, things like that. And then there was also Senate Bill 790, which continued the Women's Health Advisory Committee and extended that so that it can continue doing the work that it's doing. Senate Bill 77 authorizes the court to terminate a person's parental rights based on a criminal conviction of sexual assault. So if it's in the best interest of the child, so if there is a guardian or parent who sexually assaults a minor, then that is grounds to have their parental rights actually. I didn't realize that this needed to be a bill, but apparently it did. And then one bill near and dear to my heart was House Bill 2466, championed by Representative Sarah Davis and Senator Joan Huffman. This is a bill there, and I can speak to this a little bit because I helped Doctors for Change made an elective at Baylor College of Medicine focusing on kind of getting medical students involved in health policy research and writing op-eds and policy briefs, things like that. And I was in the first class that participated in that elective once it got put together. And my team put together a brief on the status of postpartum depression in the state of Texas. And since Texas did not expand Medicaid, the Medicaid for pregnant women expires at 60 days after delivery. And while there is auto-enrollment in Healthy Texas Women, because that's a newer program, they might have to change providers because providers aren't taking it. Ms. Hanke talked about some services may or may not be covered, and we really tried to focus in on how this could impact postpartum depression. Interestingly, while the World Health Organization might define the postpartum period as 42 days after, your peak incidence of things like postpartum depression, postpartum psychosis, and other perinatal mood and anxiety disorders, those peak incidences are happening actually after 60 days. In 2, 3, even 4 months after delivery. From that brief and our advocacy efforts and talking with Representative Davis and Senator Huffman, we were able to get a bill written and passed that allows screening for postpartum depression of the mother to be billed to the dependent child's Medicaid. So children, the threshold for qualifying for Medicaid, if you're pregnant, it lowers. If you're a child, it's still down here. But if you're a non-pregnant woman with dependents, it doesn't come down for you. So you don't get health care. So you can't go get screened for postpartum depression yourself. But when you go see your pediatrician because your baby has Medicaid or CHIP or whatever, now because of this bill, moms can actually get screening and have that service paid for. Fortunately, it doesn't cover treatment, but at least it can identify, hey, I think you might be experiencing postpartum depression. Let's try to get you connected with some resources that can help you. So I was really happy to see that bill at least get through alive. So that's all I have. I'm sure our panelists have other legislative things that they can add to and talk about. So why don't we start with Dr. Schutt-Aine? Yes. And we'll go back towards Dr. Blackwell and just give us your elevator pitch of the most pressing issues in maternal health in Texas.
Okay. So I'm going to skip over some of the legislative stuff because a lot of it is in litigation right now. The omnibus bill that Cody mentioned, the D&E ban, is actually in trial this week, and hopefully we'll get a good ruling on that. But in terms of my elevator pitch about what I think we need to advocate for, anybody who's heard my bio is not going to find any of this to be a surprise, but I think the two big things on my list are contraception and abortion. Any health problem, all those health problems that Dr. Blackwell talked about, including and those causes of death sometimes that are not necessarily pregnancy related, things like domestic violence that can lead to a homicide. So all health problems are typically worsened by pregnancy, or the health problem can negatively affect a pregnancy, right? So we talked about tuning people up and getting people in the best possible shape that they can be in before they're pregnant. And that's great if we can do that, so we need to do that. But if they're getting pregnant while we're trying to do that because they don't have access to contraception, then it doesn't really help. So really the importance of planning a pregnancy, right? And you can't do that if you don't have access to safe, affordable, effective contraceptive methods. Some problems can make it harder to contracept effectively, right? Drug addiction, mental illness, sex trafficking, women with these conditions, people with these conditions may find it harder to contracept. It still doesn't mean that they should be pregnant, so if they get pregnant, they need access to safe legal abortion. So those things are incredibly important. Healthy families need healthy parents. right? They need healthy moms. Parents, I say moms, but they need healthy parents. And contraception is an integral part of people having healthy lives. I don't think we like to think about this or talk about this, or we don't really think about it a lot because we live in the U.S. and we're in Houston and we're near the biggest medical center in the world. But pregnancy and childbirth are among the most dangerous things that a woman can do. Right? There are things that are more dangerous, like getting your car and driving on the highway in Houston. But in terms of just kind of natural physiologic things, it's one of the most dangerous things that a woman can do. And people take these risks all the time, right? I took them twice because I wanted to be a mom. People's partners take these risks. People love take these risks because they want to be a parent. And that's wonderful. And we do it, and that's fine. But nobody should be forced to take those risks because they are not ready to or not wanting to parent. And then, so that's kind of my 2-minute pitch. The last thing I'm going to add, we talked a bit about Texas Healthy Women, and Texas Healthy Women was what the state proposed as an alternative to the women's health program that Planned Parenthood and any other abortion provider was kicked out of after the 2011 legislative session. And basically the language is that if you affiliate with an abortion provider, then you cannot take this program. So much so that any physician who wants to sign up to become a provider with Texas Healthy Women has to sign a piece of paper that says, I will not and do not perform abortions. So you're limiting the providers who can take that program, who might be willing to take that program, to make a decision between whether they can offer some of these services to their patients or whether they can provide abortion to their patients. So it's okay, but it's not that great of a program because it has its own issues.
Anne and I are like almost the same person. So what I'm going to say is really going to echo what she said, but I think it's, while our focus is on maternal health, and motherhood is a lifelong commitment, I think it's really important that we realize that pregnancy is just one phase of a woman's life, and that we can't just focus on prenatal care, intrapartum care, postpartum care, although that is really important to decrease maternal morbidity and mortality. Outside of pregnancy, it's just life. It's not a stage of life, it's just life. When you're not pregnant, you're just going along and you're living your life. So we can't treat a woman as if, she's only about pregnancy. So I think it's really the importance of general care, well-woman care, and family planning cannot be overemphasized. And like Anne says, if you aren't pregnant, you can't have a pregnancy-related problem. You can't have maternal mortality if you are not pregnant. You can't have maternal morbidity if you aren't pregnant. And pregnancy is great. And like Anne says, I did it 3 times. I would probably do it again. But I learned that I'm old and I should not. Old and black. And I really should not do it. But I think that it's really important to realize that we are asking women to take on a risk that a lot of women gladly take on. But if they do not want to take on this risk, they should not have to take on this risk. So access to health care so that they can be the best woman that they can be apart from pregnancy, because you want healthy mothers to be able to take care of their kids whether or not they want another one, and just be good, healthy people. But contraception and access to safe, legal abortion is really important. And then I think briefly on one of Dr. Bucko's slides, it mentioned that unsafe abortion is a cause of maternal morbidity, especially in the developing world. Let's not make it so that's a cause of maternal morbidity here.
Just real quick, I want to make a plug on that. I crunched the numbers recently because of a riveting Facebook debate, and because I can't walk away. And if you adjust for population and a couple other confounding variables, your risk of dying from pregnancy, or delivery, I should say, versus your risk, so a pregnancy-related death, versus dying from a safe legal abortion, the ratio is like 250 to 1. Like pregnancy kills a lot more people in this country. I say pregnancy, but you guys know what I mean. Being pregnant and all the things that come with that kills more people than abortions. I think the last one I checked, there were like 5 confirmed cases in an entire year of a safe legal abortion leading to something like that in the entire country. Yeah. So let's not go back to constant.
Well, I would have to agree with these 2 ladies. I think access to care is significant. I think it'd be really challenging to try and get from Texas, but I don't think we should give up as much as we want, because that's the only way it's really going to change. As far as other bills, I think I'm really glad they extended the bill for the maternal mortality morbidity task force. That allows us to look into some of those deaths and get more information to help to plan for what we should do differently. But if I was going to pick one, yes, it would be access to care funding so that women have access to care.
I think we're going to get repetitive, but the 2 things that I think that we should focus in on that there are still opportunities for improvement are rolling out contraception and long-acting contraception for our patients. I think that there are individual health benefits to our patients, and there are societal benefits of decreasing unwanted pregnancies, as well as not having recurrent pregnancies in women that have chronic conditions. That's a huge issue when you look at the morbidities that we're seeing in our patients. The other key area is improving or extending access in the post-delivery process for inter-pregnancy care. There's so many women in our city that are sick and they get cut off either at 60 days or at a year. We haven't had a lot of success in our Medicaid patients to get onto other plans to extend out to a year. It's just, I don't want to be unfair to the people that were very thoughtful about trying to do this, but the implementation hasn't worked very well yet. But there's such need in that critical percentage of people that have these multiple severe comorbidities.
So at this time, we'll open it up to the floor for questions. If you'd like to ask a question to just the panel, just say this question to the panel. If you want to direct your question to one of our particular speakers, feel free to do so. And I can come around with the mic. So raise your hand if you have something to ask or comment. It's very good to take a talk.
Thank you for all of you. So in all of this, access to care is kind of the #1 issue. So if I was to have a magic wand and would ask you what can be done to increase access, so it appears that providers another issue. It's more like willingness of the women or not informing the women about those services. So how do you see the solution? What can we do about that?
You have a magic wand, Ruth? Okay, all right. If you have a magic wand, I'd like to change the attitude in people, the decision makers in Austin, so that we can get some of these things. But okay. Change this. That is awesome.
You don't need magic.
It's hard work, but not magic to get done.
That's why we're here, because you don't need magic to change this.
So I think there's a couple of things. One, you would have to wave your magic wand to do general access to care, and one of the things that we could have done that we did would be to expand Medicaid to cover, a large portion of the people. The other thing with respect to some of these different programs, it's talking to some of my OBGYN friends and colleagues, it's like even if they are in part of this program, like say you have a private provider who has one of these programs, it may be really difficult for a patient to figure out who this person is, go to this person, get this particular service from this person, versus if you could say, I wonder where I could plan my pregnancy or my parenthood. maybe I could go to Planned Parenthood and get contraception. But places like that have been kicked out of these programs. So the things that would be easiest to patients when they're just kind of in general thinking about what they want to do have been made harder. So it would be get rid of the people who are making those choices.
I think one other thing, and it's really I'm not, first of all, well enough versed in it to really get into a deep conversation about it, but I think it's also just another huge topic. You know, a lot of these slides that were, you know, when we showed the disparities in healthcare, we saw that African Americans, Latinas are far more likely to have bad outcomes from pregnancies, right? So how do we focus on those groups? How do we reach out to those groups and get them access? There's an entire movement which is, you know, just called reproductive justice, right? And it's about how is it that women, and it's a movement led by women of color, particularly African American women, and a lot of it addresses a lot of the distrust sometimes very well founded in minority communities around the medical community. And I think that's a problem with sometimes getting women to accept LARCs, right? Like, you're putting what in my body and it's going to do what for how long? And then I have to come back, right? So there's, you know, ideas of reproductive coercion, particularly around women of color. So I think there's a lot of trust and other work that needs to be done as well with your magic wand.
Dr. Blackwell, did you want to comment, or?
No, I mean, the only, there's a practical, I mean, there's a reality tomorrow that we've got people getting pregnant and we need to take care of them. How do we improve the access to that? There are lots of strategies around that we probably underdo. I'll give you an example, and this again gets to how health systems decide how to do things. Harris Health System takes care of a lot of underserved women. Made a decision to not give free pregnancy tests in a large percentage of their clinics because they didn't believe that it was a cost-effective approach. And that, strategically, from a lot of people in women's healthcare, isn't the smartest thing. So if you can get free pregnancy tests to your patients, get them early access, enroll them, and get them into the system, I think there's pretty reasonable evidence that that's effective. The second thing that the Harris Health System does that's good, and a lot of other things that we could probably do more of, is putting more community health centers in the communities of underserved patients. There's no doubt in my mind that we probably don't do that enough in Houston compared to other larger cities where we're trying to do outreach to communities that need that type of access. So those are two very practical things. If we force every woman to come to the medical center for care and take 3 buses and have to pay for parking or have to drive all the way down to come to LBJ or all the way down to Bentog, that's a lot of inconvenience if we're trying to improve access. So there's a lot of things that could be done if systems wanted to do it that way.
If they had the money.
Well, the challenge right now, and I don't want to beat up on health systems too much, is they're all overwhelmed. Harris Health System in particular is completely overwhelmed, taking care of really, really sick adults that need dialysis, that have serious surgical problems, and women can go anywhere. That's not their crisis point. So they say, well, we'll just let the women go to the other systems and they'll get good care and not serve that patient population. It's a crisis in our town in taking care of our underserved patient populations.
Actually, when I said that 2013 what happened, I wondered when we put that policy, you actually did, because you could see where the for entry into first trimester prenatal care, because it had been going up, and then like for Hispanic it dropped. And so actually thought about that. Like what year did that happen?
It was coincident with leadership change, and that person changed after 18 to 24 months. So we'll see if that changes again.
Thank you for your time today. My name is Avneen. I'm a pediatrician serving a Medicaid population, and I was wondering, in terms of a couple things, we know in our visits, child visits, we have alone time with the adolescent, and that's a great time to do some contraceptive counseling. And I think that could potentially be a way to get them thinking about it, so as they are further in their lives as women, they are still constantly thinking about what are my choices and for reproductive health. So are there things that you could could talk about in terms of the laws in Texas regarding adolescent and consent for certain types of contraception, and then also things that you could recommend in terms of when we transition them out of our care when they're 18, where they could go, I guess.
So if I'm misspeak, I just had a conversation with one of our legal clinicians a few weeks ago about this, and my understanding is that for adolescents who have Medicaid, they can consent to prescriptions of hormonal contraception on their own, because that's kind of the federal mandate. But anyone who has private insurance or is uninsured has to have parental permission for birth control. So it does get sticky, but if you do have a large Medicaid population, I think that it is wonderful as a pediatrician if you take that time to talk to your patients about contraception, what their choices are, have a handout where they can, you can give it to all of your adolescents starting at whatever age, so when the mothers fly off the handle about, why are you talking too much? Aren't you happy? I give it to all of my adolescents who are this age, right? And then there are some pediatricians I know who, will put in, Nexplanon, which are super simple to put in. Some put in IUDs, prescribe, contraception, just depending on what your comfort level, obviously, with all of that is.
And then I would say I went to a meeting a couple years ago, and one of the things that they talked about was, especially for a younger population, instead of talking about large or long-acting methods, kind of switch the phraseology to forgettable contraception. Because something that's, long-acting is they're just like, I don't want something in my body for that long, and I don't want to make this decision, but if it's more like it's just there whenever you're ready, okay, that sounds great.
Other questions?
What you suggested about adolescent access, minors access to contraception, Medicaid or but the data Texas required. But those of the other clinics in our city that are funded by tax pain can also allow minors to get contraceptives without pregnancy. And we have some in the city that
How does anyone know? I mean, I'm an OB/GYN. I couldn't tell somebody, go to this one or go to that one because of your insurance or your lack of it. Yes.
Hi, so thank you guys so much for having this panel. I just wanted to ask, given the opposition in Texas legislature about a lot of things a lot of solutions y'all have covered, so Planned Parenthood for one, abortion, access to contraceptives, Medicaid, what are some things that we can do legislatively to improve healthy Texas women, knowing that they have this, already inherent opposition to expanding a lot of coverage for women?
The first thing you can do, or the best thing I think you can do, is get more women elected to the state legislature. I think that's your fundamental issue at a state level. And then I think the other part of it is figuring out what is it that resonates with the state legislature and why they do things, right? There's a strong religious bent here in Texas about contraception and abortion rights that's never going to go away, and is a very difficult swim upstream. I think the most effective arguments when you're dealing with politicians and other business leaders are the business arguments for these choices, related towards unwanted pregnancies, related towards contraception, and the societal burdens of these sorts of things. That's the language that they listen to. That's the currency that they trade in making decisions. And I think that we can do that better as we try to advocate for the things that we believe in.
And also maybe incremental, so maybe asking for coverage like after pregnancy for a year to start with, rather than ask for Medicaid for total volume. Maybe incremental would work.
I'll just add, there are lots of organizations, both local and national, that do this work and who always are looking for volunteers and people to come and go to the legislature and talk to people and all those sorts of things. So Doctors for Change does it, so do it with Doctors for Change. I have actually some things that I brought from Planned Parenthood. 5 things that you can do to help, so I'll leave these. We have a very active public affairs department. There's Planned Parenthood Texas Votes. I don't want to just talk about Planned Parenthood things, but there are lots of organizations who are doing this work every day, who are always looking for people to come help do the work as well, and be real people's voices in the ears of the legislatures.
We are unfortunately out of time. I know we could stay here all night talking about these issues. I wanted to first, if we could get another round of applause for our wonderful panelists. Second, one thing I noticed, there are 5 men in this room. And I agree 100% that getting more women into positions of power in the legislature, things like that, is absolutely important. But also that it's important, like, getting men aware of these issues. Like my brother, I guarantee you, he doesn't know any of this. Despite my best efforts, he's like, Cody, I don't care. But he's 20, so like he'll learn. But women's health, maternal health, is just as important for the dads of tomorrow, and the grandpas and the brothers and the sons. And so, I would encourage you to reach out to male colleagues, boyfriends, brothers, family members who are maybe not as connected to this simply because they can't get pregnant, or at least not yet. There have been uterine transplants in Sweden. So the last couple of things, there is a little sheet on the table that is kind of our metrics of how you thought this forum went, and we would very much appreciate it if you could give us some good data on what we did well and what we could improve upon. And then also there is this slightly bigger sheet, which is your advocacy action plan, and this is for you to communicate with us about how you're going to move forward. You can give us your contact information if you want to get more involved with Doctors for Change. Like I said at the beginning, we do have these 5 core committees, but we touch kind of on everything. I mean, we really have our fingers in all the pies. And it's a really wonderful organization. We would welcome you to come be a part of our team. Please feel free to leave any constructive criticisms or ways you think we could improve. And if you have any more questions, I'll hang around. Mehdi will be around if you have questions about the organization. So yeah, thanks for coming, guys. Take some free food.